Hello and welcome dear learners on the NPTEL course on Healthcare Quality Management, Infection Control and Patient Safety. In continuation with the first module on Foundation of Healthcare Quality and Infection Control, let me just go in discussion with the evaluation and accreditation of healthcare organization in the chapter 11. Here we will be focusing on the history of accreditation bodies in healthcare and other international organizations which will be talking about the evaluation and accreditation of healthcare organizations. So if you go into the history of accreditation, you will find that in the early years, that is the early 90s, the modern focus on measuring and improving healthcare quality began with the start of scientific medicine. Medicine in the US saw major changes in how it was run and practiced. The key events that I want to focus that shaped this period was the Flexner report. After the Flexner report, there was the formation of the American College of Surgeons, that is ACS. The creation of the Hospital Standardization Committee, Flexner report, ACS and Hospital Standardization Committee. The Flexner report was a study focusing on existing condition of American medical education. It was sponsored by the Cognizant Foundation. The study was carried out by Abraham Flexner, a professional educator with no prior experience in healthcare. Can you imagine actually to see a person who identifies and makes such a remarkable change? Flexner visited medical schools across the country for his observation. He was thoroughly searching it, making it more fine actually with his research. What did he do? He concluded that only a limited number of schools were comparable in quality to Johns Hopkins. There was a benchmark of Johns Hopkins and the other schools were compared to it. Johns Hopkins was widely considered the gold standard for medical education at the current time. And this current time was used by Johns Hopkins actually for that process to understand how the other schools were compared to that. American College of Surgeons, the ACS. The ACS was officially formed in 1913. It was formed to promote the highest professional standards for surgeons. It was the first specific medical group of its kind in the US. It was very popular because of this specification. Franklin Martin, a Chicago surgeon, organized the Clinical Congress in 1910, which allowed surgeons to observe experts at work. The end result idea. In 1910, surgeon Ernest Godman shared his end result idea. Godman believed surgeons and hospitals must have tracked patient after treatment to see if it was successful. It was very fantastic actually to see that this advent made actually to understand the entire process. Analyze this information to find ways to make care better. And lastly, share all results publicly. So what does it improve? It improves the visibility of the hospital. It makes actually the key players just like surgeons and all that accountable for their care. From tracking to analyzing and sharing. So you may find the TAS over here. This was what the Codman believed. Dr. Martin and Codman, they formed a hospital standardization committee. The committee was formed under the ACS with Codman himself as chair. Avidus Donabedian called Codman a towering figure. He's placed it. Why? Because in quality improvement, Codman was a towering figure. What did he do? He did a simple idea. If treatment failed, the hospital should ask why not. I repeat, the simple idea was if treatment failed, The hospital should ask why not. The five hospital standards. What are those? The Hospital Standardization Committee continued its work without cutback, focusing on organizational rules instead of the end result idea. They developed only five original minimum standards for hospital. What were those standards? They were: the medical staff must be organized. The emphasis of organization is listed over here. The staff must be licensed physicians who are skilled and honest, which is very important to see the standardization process, that the emphasis on licensed physicians was being given. The staff must adopt rules to revive and analyze the clinical performance, which is very important to be taken as a very key decision and even applicable in the modern times. Accurate and complete record must be kept for all patients. It is very important to see that the evolvement of the current MRD is where you may find the words very true to give this accurate and complete records. Services for finding problems. The problems can be from diagnosis, problems can be from treatment. All this must be available under expert supervision. You can interlink that all these things which are stepped down in the five original minimum standards for the hospitals make it very important the hospitals to improve. What is the first survey? From 1918 to 1919, the survey speaks about the first take based on the five standard took place across US and Canada. They did an entire survey for this. 692 hospitals as in sample with over 100 bedded were surveyed. To make this as an evidence-based research, to make a remarkable change, you need to take an efforts of the survey. Survey as a research. Only 89 hospitals, a very small percentage, met all five standards. So can you imagine from 692 to 89, what is the number where you can find entire gamut changing, where most of the hospitals were found that they were not following all these five standards. A major issue was the only 301 of the 692 hospitals even had proper medical records. I would like to emphasize over here the importance of medical records, the importance of the details that are fetched to the medical records, the importance what a medical record really is to the hospital administrators, to the clinicians, to the nurses and the other staff. The evolvement what we have seen now in the medical records and the medical records department lies actually to the role what this has taken from this. Names of the hospital that passed or failed were destroyed to prevent a public scandal. Only the numbers and common problems were released. So the importance faces that how a hospital need to emphasize on taking these five standards. Now come to the discussion of creation of the Joint Commission. The need for a new group. The hospital rules program run by the American College of Surgeons ACS was working well, but it became too much work and distraction for them. And this was some voluminous work which was making them their task more distracted. In 1950s, the ACS became looking for a new group to take over the program. This was something like handling a work actually to a much more expert group who can take it as a separate task. The American Medical Association didn't want to run it, but they also didn't want to see that American Hospital Association to control it alone. So what they want? They want that it is not the work that they have to take ahead, but yes, they don't want even the complete autonomy of the AHA. What the group did, the group decided to meet in the middle and create a brand new organization. So where the stepping stone of taking the decision of identifying a new organization was settled. And there where you find forming the Joint Commission. The new group, the Joint Commission on Accreditation of Hospitals, was officially started in 1951. It took years of work, research, and formation to make JCI happen. Its board includes representatives from several major health organizations: AMA 7 members, AHS 7 members, ACS 3 members, and American College of Physicians 3 members. Medical Association, Health Association, College Surgeons, College of Physicians, and one person from the Canadian Medical Society. All these representatives made to happen the organization. Now comes defining the accreditation. During the talks to form the new group, the word standardization was swapped out for accreditation. There was no to be seen as for standardization and yes for the accreditation. Accreditation meaning checking hospitals against the agreed upon rules in a structured way. So you may find what are the agreed rules, you have to check according to that. Even though it started with hospital, the program has grown to include many other types of healthcare. And you may find a lot of primary healthcare, laboratories, other services in the healthcare took over the period of time to take this program ahead and to make it more successful. So what is the worldwide growth of it? After the Joint Commission began in the US, Canada, and later Australia started their own accreditation program. They progressed the way actually the year passes. Since 1990, the number of programs worldwide has doubled every 5 years. So you can understand how people are really in pro to get this accreditation. This growth has been especially strong in Europe, which now has 11 active programs in countries like France, Germany, and UK. To help this program develop and work well together, International Society for Quality in Healthcare, Ishikawa, started a project called as Alpha in 1999. What is ALPA? Alpha helps healthcare group people meet international rules for national accreditation. It abides to see that these people meet international rules for the national accreditation and work on that part. Does it ensure the scope and the benefit? Accreditation rules now cover many different types of healthcare organizations. You may find the inclusion of hospitals and clinical labs, nursing homes and home care facilities, ambulatory care, that is outpatient care, emergency transport providers, who are seeing the accreditation rules now to be covered up. So these standards are used in both government funded public and private healthcare institutions. The positive rules that are made actually to be resultant of this accreditation includes creating uniform policies, that is same rules and procedures and patient records, measuring performance and clinical systems. These benefits help convince the leaders in the healthcare. All the top leaders actually who are trying to adopt the program are well convinced with all the things in line: uniforming policies, improving the performance, working on the clinical system, and accepting what is developed over there to give the positive results of the accreditation. Now comes in the second discussion, that is Global Health Quality Groups, that is JCI, the Joint Commission International. JCI was set up to serve healthcare organizations outside the USA. The groups was being seen was not from US. Since healthcare services differ greatly around the world and you may find the complexity is completely different from US to others, Just meeting the basic rules or getting a simple certificate is not enough. The purpose of JCI, because the need of the world are different from those in American healthcare. American healthcare has a different need. The other partners in the global world has a different need. A separate group was needed to create rules for global community. The JCI Joint Commission international rules for hospitals are divided into two main sections. The section 1 focused on the patient. The focus is more on goals for keeping patients safe worldwide, IPSG. Second is getting access to care and making sure care continues to the patient, that is ACC. Third is the right of the patient and family, that is PFR, where it emphasizes mainly on the rights of the patient and the family. Fourth is how patients are checked and assessed, that is AOP, where it is emphasizing more on how they are checked, if anything is missed or not. Fifth is more on the actual care patient receives, that is COP, which is differing from all the first one, which is also in continuity to be seen as. The next line is the anesthesia and surgery rules, that is ASC. Seventh one is managing and using medicine, that is MMU, managing and using medicines. Eighth one is teaching the patient and family about their health, which is more towards the promotional and promotive aspect of the health. The section 2 of the JCI speaks about focusing on running the hospital. This is very emphasizing projecting on how you can provide the care more better. The first comes over here, making quality better and keep patients safe, QPS. Stopping and controlling infection, which is very important, that is as PCI. Third being seen as how the hospital is governed, led and directed, which is very important for the leaders, for the top management. Making the patient built and keep it safe, where you find even it is a safetier place to be seen as, FMS. The SQE stands for staff skills and training, which is like in board and even sending the staffs to be get more skilled. And the last is managing all communication and information, which is a highly developed area to be seen as, and a major emphasis going on not only doing the communication but even exchanging it and improving it with the help of information. You may find a list of other global accreditation groups. These are very helpful to understand what is going on globally. Many other countries have their own health quality groups. It is very important to have for every country a health quality group. Canada having its own, the Canadian Council on Health Services Accreditation, CCHSA. Australia having its more than Australian Council on Health Standard, that is ACHS. England, UK having its own standards health quality services, HQS. South Africa having its Council on Health Service Accreditation for South Africa. The Irish Health Services Accreditation Board is from Ireland. The Malaysian Society for Quality in Health is from Malaysia. And the New Zealand Council on Health Standard is from New Zealand. UK and Europe and Hong Kong, they trend on the accreditation scheme. It is more being seen like what different schemes we do have. So quality is also being seen into this gamut. The lessons to give and to be followed from all these global accreditation groups is more like how they are experimenting it. The US-based Community Health Accreditation Program, CHAP, the Accreditation Commission for Healthcare, ACHC, and Healthcare Quality Association on Accreditation, HQA, is also one to be studied thoroughly if you have to take lessons from the global accreditation groups. So in summary, the healthcare quality efforts which started in the early 90s driven by the Flexner report, criticizing the medical school and even identifying what are the problems that they were having. And ECS, the end result idea, which was tracking the patient outcomes, which was making it like how it has remarkably changed actually the reasons actually we have to look back actually to our systems. The first standard focused on basic requirement like organized medical staff and accurate patient records, organization and seeing the records of the patient, improving it actually. The ACS programs was transferred in 1951 to Joint Commission, which replaced standardization with accreditation, a systematic quality check, where we find that swapping was not just to change the word but to change the entire gamut of replacing this word with a systemic quality check. Accreditation quickly grew from checking hospitals to covering many other areas apart from the hospital: labs, maternity home, home care, and all other. Quality monitoring expanded internationally with organizations like JCI, Joint Commission International, JCI, which creates global standards and similar national bodies in Canada, Australia, and Europe. Even we do have accreditation body which comes from NQAS, which works under the Quality Council of India, NABH, which also equally comes from the accreditation topper body from Quality Council of India. Thank you very much.